Good evening, ladies and gentlemen. It is not unusual to encounter pelvic organ prolapse such as these of different level defects of different stages of various size and shapes in our day-to-day practice. This is the ancient treatment which was adopted way back in the era of Hippocrates, where the lady with prolapse will be tied down like this and she will be shaken till the prolapse goes back into her pelvis. Over the time, evolution has happened in the surgical management of pelvic organ prolapse, and till recently, majority of the pelvic organ prolapse are managed by vaginal hysterectomy with anterior and posterior repair. We have simple procedures, vaginal repairs, abdominal repairs, combined repairs, even minimally invasive approaches like laparoscopic or robotic techniques. We have partial or even total replacement with synthetic meshes. And the surgeon has the option to choose reconstructive surgeries over obliterative surgeries, and the laparoscopic or robotic techniques over the traditional vaginal or abdominal approaches, native tissue repairs over mesh procedures, and uterine preservation over hysterectomy and reconstruction. When a patient presents to you with isolated anterior or posterior vaginal wall prolapse, the traditional native tissue repair as anterior or posterior cartography is offered. But when there is a coexisting advanced apical prolapse, then the surgeon is forced to decide reconstruction, and having decided on reconstruction, the surgeon should make sure to offer apical support and support to the anterior and posterior vaginal wall. If a patient comes to us with a wall prolapse, we have the option to choose a vaginal approach, abdominal, or minimally invasive approach. We also have the option of choosing native tissue repair over the mesh repairs. The commonly adopted vaginal native tissue repair is the sacrospinous ligament suspension, and commonly adopted abdominal repair using the mesh is the sacrocolpopexy. These procedures can be carried out using the laparoscopic or robotic techniques. If a patient comes to us with uterovaginal prolapse and you decide on doing the hysterectomy and reconstruction, we have the option of choosing the vaginal, abdominal, or minimally invasive technique. And we also have the option of choosing the native tissue repair or the mesh augmented repairs. So the commonly adopted technique is, after the vaginal hysterectomy, we resort either to the sacrospinous ligament suspension or high uterosacral ligament suspension. In the abdominal procedures, do an abdominal hysterectomy, and it is preferable to go in for subtotal or supracervical hysterectomy and sacrocolpopexy. This can be done by the laparoscopic and robotic techniques. If a patient comes to you with a uterovaginal prolapse and she decides to preserve her uterus, then we also have the option of choosing the vaginal, abdominal, or minimally invasive approaches and the native tissue repair or mesh repair. The commonly adopted native tissue repair is the sacrospinous ligament hysteropexy, and in the commonly adopted abdominal hysteropexy is the sacrohysteropexy using the synthetic mesh, and this also can be done by the laparoscopic or robotic techniques. Whatever the operation reconstruction type adopted, the objective should be that the vault should be suspended to the uterosacral ligament or to the sacrospinous ligament or to the anterior longitudinal ligament. So the pubocervical fascia and the rectovaginal fascia should be attached to the vault. Yes, surgical decision making is a complex process. No single procedure fits all. Which operation for which patient is $1 million question. You need to select the right operation to suit the concerned patient in order to accomplish a successful outcome. Success means there shouldn't be any complication, there should not be any persistent or recurrent defect or prolapse, and there should not be any new defect or new prolapse occurring in future. What are the factors that determine the surgical decision in the surgical management? There are patient factors and the level, stage, and the involvement of the multiple compartments also to a major extent decides the approach, and the surgeon's preference also is very much important in choosing the surgery. We use the Professor Delancey's level 1, 2, 3 and the anterior, middle and posterior compartment defect levels, and then choose accordingly. With reference to the patient factors, the age of the patient, overall health, and the previous prolapse surgery should be considered. Severity of the symptom or the patient's desire for future childbearing or desire to preserve the reproductive organs should be considered, and one should also consider the recovery time planning. Having considered these factors, we should see that the patient-centered care is given to her. Align the procedure with patient's expectations and safety, and offer a durable repair which will improve her quality of life. The apical support is provided by the uterosacral ligament, cardinal ligament complex. Any defect in that results in apical defect and apical prolapse. It can present as uterovaginal prolapse or it can present as wall prolapse. There are so many vaginal apical suspension options available to us. The most commonly adopted ones are either the sacrospinous ligament suspension or the high uterosacral ligament suspension. The McCall-Calder-plasty is a simple apical suspension technique. It also has the additional advantage of preventing enteroceal development in future. Among the abdominal apical suspensions, you have the high uterosacral ligament suspension, sacrohysteropexy, sacrocolpopexy for wall prolapse, sacrocolpopexy with the subtotal hysterectomy for patients with uterovaginal prolapse. All this can be done either by open technique, surgical technique, or laparoscopic or robotic technique. This is a sacrospinous ligament suspension where the apex is anchored to the sacrospinous ligament which lies within the coccygeus muscle. And in the high uterosacral ligament suspension, the apex is anchored to the intermediate portion of the uterosacral ligament. Both these techniques they use the vaginal approach and it involves the native tissue repairs. The uterosacral ligament suspension technique has an added advantage of you can do it by abdominal and laparoscopic or robotic technique also. It is worth remembering that both techniques are valuable in treating uterovaginal prolapse in advanced in stage 3, stage 4 prolapse cases, as you see here, or even in the wall prolapse cases. Sacrospinous ligament suspension has many advantages. With low mobility, simple, effective, even unilateral fixation is adequate. It is native tissue repair, no mesh-related complication. You can even preserve the uterus and do the suspension. But the important point to remember is not only it distorts the vaginal axis, the high occurrence of recurrence, particularly in the anterior compartment, as high as 37%, which discourages the surgeons to consider this operation. High uterosacral ligament suspension is also an autologous, uses the tissue and it is mesh independent, ideal for advanced level 1, stage 3, 4 defects, and it preserves the normal vaginal length and axis. But the important point is the proximity of the ureter to the uterosacral ligament, which makes the ureter vulnerable for injury during the procedure. So paraoperative cystoscopy is important to exclude and verify the integrity of the ureter. What is important to remember is both in sacrospinous ligament suspension and in high uterosacral ligament suspension, one should combine level 2 anterior or posterior defects if the patient has coexisting defect, or even level 3 anterior defect. All these should be repaired separately. Sacrocolpopexy is an apical suspension method. It uses the Y mesh. It is considered as a gold standard operation because it restores the near normal vaginal axis and it has a very low recurrence. It can be done by abdominal route, by laparoscopic or robotic technique. The reported success rate and comparison between the vaginal suspensions to abdominal apical suspensions show that the abdominal suspensions are superior compared to the vaginal apical suspensions, though the subjective outcome is more or less the same. The Cochrane review has shown that sacrocolpopexy, when compared to vaginal apical suspension, has high efficacy, low recurrence, not only subjective but anatomical too, low need for repeat surgery for recurrence, and even though the operating time is prolonged with sacrocolpopexy, considering the efficacy, it has the grade A recommendation, but it is also associated with high perioperative complications as shown here. Cochrane review shows that abdominal sacrocolpopexy has a low recurrence rate and low dyspareunia rate. On the contrary, vaginal apical suspension like sacrospinous ligament suspension has low morbidity and a low operating time. So often the surgeons would wonder whether to do sacrospinous ligament suspension or abdominal sacrocolpopexy. So how to choose which one to do for which patient? So if your patient has high risk of recurrence, like she is a young patient, obese patient with advanced stage 3 or 4 prolapse, better to choose the sacrocolpopexy as apical suspension. But if the patient has low risk of developing recurrence with history of previous laparotomy, particularly if you are planning to do concomitant hysterectomy, it is better to go in for vaginal apical suspension. While planning for apical suspension, the surgeon should decide whether to do hysterectomy or not. Because vaginal hysterectomy used to be the standard step in the operative treatment of uterine prolapse. In fact, it is one of the most commonly listed indications for hysterectomy, but the clinical data on its effect are limited. Uterine preservation and hysterectomy both have advantages and disadvantages. So, what are the advantages with hysterectomy? With hysterectomy, there is better access for high wall suspension, there is low recurrence of prolapse, and it treats the existing uterine pathology and avoids future unanticipated malignancy. So, ladies and gentlemen, if your patient has fibroid uterus, adenomyosis, endometriosis, or she has dysplasia, or with elongated cervix, if she is an obese patient with high risk for endometrial CA, it forms a relative contraindication for preservation. Similarly, if the patient has abnormal uterine bleeding, family history of BRCA1 and 2 positive, or patient has Lynch syndrome, or on tamoxifen therapy, it's better not to preserve her uterus. So, regarding the unanticipated pathology of genital tract malignancy, cervical, uterine, ovarian, or endometrial carcinoma, even though they are meager contributions, it is worth considering all these factors in planning the uterine preservation. What are the disadvantages of hysterectomy? When you do the hysterectomy, it is associated with more complications and more morbidity. Particularly, the mesh exposure rate is high if it is combined with hysterectomy. And it is also associated with iatrogenic menopause development, and the future chance of fertility is totally eliminated. So, it is worth preserving the uterus and doing the reconstruction in young or middle-aged women, menstruating women who desire fertility. And in women in perimenopausal or postmenopausal, we recommend doing the hysterectomy and reconstruction. What is the current trend? Up to 60% of women decline hysterectomy if an equally effective surgical alternate is available. 20% of women still prefer uterine preservation despite its slightly inferior efficacy. What does the evidence-based guidelines say about the hysterectomy with apical suspension over uterine preservation? Concomitant hysterectomy with apical suspension is associated with low risk of repeat surgery for pelvic organ prolapse and with increased perioperative morbidity. So originally it was preferred to do the hysterectomy and do the reconstruction. And the large database studies have shown that hysterectomy is associated with low reoperation for recurrence and a high complication rate when you combine it with hysterectomy. There are other researchers have shown that there is no difference in the recurrence and reoperation rate between the hysteropexy and hysterectomy and reconstruction, but the hysteropexy is associated with less operating time, low blood loss, and less mesh exposure rate. When you compare the vaginal sacrospinous hysteropexy to the vaginal hysterectomy and native tissue repair, and there is consistent level 1, level 2 evidence to show that there is no difference in the outcome between these two procedures, but the hysteropexy is associated with reduced blood loss and reduced operating time. When you compare the abdominal sacrohysteropexy to the vaginal hysterectomy and apical suspension, the success rate is similar between these two techniques, but the reoperation rate is much less in the hysterectomy group. The comparison of sacrohysteropexy versus the vaginal hysterectomy with the uterosacral ligament suspension shows there is similar success and reoperation rate between these two techniques. However, when you compare the sacrohysteropexy to sacrocolpopexy with hysterectomy, then the efficacy, the success rate of sacrohysteropexy is lower. The usage of mesh in the reconstruction, either doing sacrospinous mesh hysteropexy versus hysterectomy and mesh reconstruction, there is consistent level 2 evidence to show that the anatomic success is similar between these two groups. However, the rate of mesh exposure is much higher in the hysterectomy group. So, with the available results based on the large database studies, the 7th International Consultation on Incontinence concluded in 2023 that vaginal hysteropexy is a reasonable option if the uterovaginal prolapse is in its early stage, if preservation of the uterus is desired, provided there is no contraindication for uterine preservation. Both the hysteropexy and the hysterectomy and reconstruction are equally effective, whereas the hysteropexy has reduced blood loss and less operating time. However, the long-term data of uterine preservation are limited, and the risk of future hysterectomy are unknown. In 2025, the HOPE study concluded that following the uterine preservation, the recurrence of prolapse is significantly low compared to following hysterectomy and reconstruction. The vaginal mesh reconstruction has no advantage over the native tissue repair reconstruction. On the contrary, mesh exposure rate was pretty high with the vaginal mesh reconstruction, as high as 18%, and 99.5% of them required another surgery to relieve them of their mesh-related complications. In patients with wall prolapse, comparing the outcome of uterosacral ligament suspension to sacrospinous ligament suspension has shown that the outcome is similar between these two groups, and there is level 1 evidence and grade B recommendation for this procedure. A comparison of abdominal sacrocolpopexy to vaginal hysterectomy and apical suspension, that is, in terms of either using sacrospinous ligament suspension or uterosacral ligament suspension, has shown that sacrocolpopexy is superior to all these techniques because it is effective, it results in a low recurrence, it requires a less need for repeat surgery for prolapse, there is less postoperative SUI and dyspareunia with sacrocolpopexy. So sacrocolpopexy has level 1 evidence and grade A recommendation. A comparison of open sacrocolpopexy to minimally invasive sacrocolpopexy shows in terms of efficacy in providing apical support and recurrence rate, both techniques have similar outcome. But the minimally invasive approaches have less blood loss, short hospital stay, and prolonged operating time. And the intra and post-operative complications are more or less the same between these two groups. A comparison of laparoscopic sacrocolpopexy to abdominal sacrocolpopexy and robotic sacrocolpopexy shows the cure rate, both objective and subjective, are similar. But in spite of it, the laparoscopic sacrocolpopexy has grade B recommendation because it is associated with less blood loss and shorter hospital stay compared to the abdominal sacrocolpopexy, which takes longer operating time and more blood loss. And we all know that robotic sacrocolpopexy is expensive and it consumes longer operating time. A comparison of laparoscopic sacrohysterectomy versus sacrospinous hysterectomy, to our surprise, shows a similar outcome. And the laparoscopic sacrohysterectomy has long operating time and hospital stay compared to the vaginal sacrospinous hysterectomy. And the study, the SALTO 2 trial, which was reported in 2023, comparing the laparoscopic sacrocolpopexy to sacrospinous ligament suspension, shows the success of apical suspension, the need for reintervention, and the complication are similar between the laparoscopic group and the sacrospinous ligament fixation group. So it is also shown that the laparoscopic sacrocolpopexy has high objective and subjective success rate compared to the vaginal mesh reconstruction and has a low reoperation rate and has grade B recommendation. When you compare the robotic uterosacral colpopexy to high uterosacral ligament suspension done by vaginal approach, the outcome is the same between these two groups, but the robotic suspension has the added advantage of precisely identifying the ureters and placing the suspension sutures on the uterosacral ligament and minimizing the chances of rectal injuries. There is a close association between the usage of mesh and particularly using mesh in the vaginal approach and reconstruction and usage of mesh with hysterectomy, particularly the total hysterectomy. A comparison of mesh exposure rate between the group who had total hysterectomy and sacrocolpopexy with the group which had supracervical hysterectomy and sacrocolpopexy has shown there is less mesh exposure rate with subtotal hysterectomy and sacrocolpopexy. Similarly, the recurrence rate is higher in those patients who had supracervical hysterectomy and sacrocolpopexy. When the sacrocolpopexy was done for wall prolapse cases, the mesh exposure rate was varied from 2.2 to 2.3. When sacrocolpopexy was combined with subtotal hysterectomy, the mesh exposure rate was 0.4 to 0.7, which is the lowest. When sacrocolpopexy was combined with total hysterectomy, the mesh exposure rate was highest, varying from 7.2 to 9.3. So, concomitant sacrocolpopexy with total hysterectomy is not recommended because 3 to 5 times increased chance of mesh exposure rate will occur. So, the usage of vaginal mesh repair as primary anterior vaginal wall prolapse or for the posterior vaginal wall prolapse is not recommended. Similarly, the vaginal mesh repair, partial or total, for apical defect, apical prolapse, with or without anterior or posterior vaginal wall defect is not recommended. Abdominal mesh repair is recommended for sacrocolpopexy. Why mesh is accepted for the sacrocolpopexy while doing the either open or laparoscopic or robotic repairs. What is the current role of mesh in prolapse surgery? It is acceptable only for abdominal procedures in cases of advanced apical posterior vaginal wall prolapse and in cases of rectal intussusception or recurrent prolapse cases either in anterior vaginal wall or in vault or if the patient has severe bulk symptoms. Otherwise, the usage of mesh, that too vaginal mesh for apical suspension, anterior repair or posterior repair is not recommended. The role of colpoclysis, particularly in elderly women who are unfit for surgery, who have no pathology in their uterus and who are not sexually active, it is an acceptable procedure. It is effective with low morbidity and it has grade C recommendation. Partial colpoclysis is preferred over hysterectomy and total colpoclysis. When a patient presents to you with isolated anterior vaginal wall descent, the anterior colpography as native tissue repair is generally recommended for primary prolapse. The usage of synthetic mesh can be considered only for recurrent anterior vaginal wall prolapse. Coexisting apical and anterior vaginal wall prolapse requires concomitant repair as apical suspension and anterior repair. The procedure native tissue repair as anterior colpography has grade A recommendation. In cases of posterior vaginal wall prolapse, native tissue repair as posterior colpography is the procedure of choice. Facial plication is superior to site-specific defect repairs. Livetoplasty is associated with high rate of dyspareunia and it is contraindicated in women who are sexually active. There is no evidence showing benefit for synthetic or biological graft usage in the repair of posterior vaginal wall. I would conclude by saying it is essential that we counsel the patient about the potential risks and benefits, complications and recurrences, and should discuss the long-term outcome and the feasibility of reoperation if there is any need. And one should plan the surgery and tailor it to anatomic correction and functional needs. Align the surgical procedure with patient's expectations and safety, and guide the patient and help her to make the shared decision making. Reconstructing a damaged pelvic floor is almost like this, and one should consider repairing it anyway.